forward. So I would like to introduce our first presenter. Dr. Gavin Britz is Director of the Houston Methodist Neurological Institute, Chairman of the Department of Neurosurgery, and the Candy and Tom Knudsen Centennial Chair in Neurosurgery at Houston Methodist Hospital. He is a Professor of Neurological Surgery at Weill Cornell Medical College. Dr. Britz is recognized as one of the nation's foremost cerebrovascular, skull base, and brain tumor surgeons and is included in the Masters of Neurosurgery book. He is on the advisory boards of the Joe Niekro Foundation and the Brain Aneurysm Foundation and serves on the editorial board for Neurosurgery, World Neurosurgery, International Journal of Vascular Medicine, Surgical Neurology International, SOJ Neurology, and dataset papers in medicine. He has authored more than 110 peer-reviewed scientific manuscripts, 30 chapters, and 2 neurosurgical textbooks. So please welcome Dr. Gavin Britz.
So what I'm going to talk today about is the feasibility of robotic-assisted stroke intervention. I'm sorry I cannot be at the conference today, but I got a prior engagement, and Jay Volpe, thanks for inviting me. So if you look at this slide now, this shows a humanoid sitting behind a console on Earth, and he's controlling an angiogram and a thrombectomy of an astronaut in space. So people, unless you know this technology, will say, well, this is impossible. How would you treat a stroke robotically, even in space? And even though this looks futuristic, this is the future. It'll happen, hopefully still in my lifetime, as I'm still getting old, but I'm still pretty young. And I think we will see this. What I'm going to talk to you today about is how we have helped develop this technology, and other centers are now taking the technology as well. And I think together with a couple of companies, this technology will be developed. So what made this possible? And I always look at the pioneers of cerebrovascular and cardiovascular, of how this happened. And I think one of the biggest things that set the stage was the shift away from open surgical vascular procedures towards the percutaneous interventions that resulted in faster, safer, more effective treatments. This occurred in the fields of cardiovascular, peripheral vascular, as well as neurovascular conditions. And the reason being is that we realized as surgeons that we had a vascular tree that we could access through the groin, or now recently the radial artery, and we can access the whole neurovascular tree. The heart could do the same, peripheral vascular do the same. And moving away from those open procedures set the first stage of robotic intervention in stroke. I think the second step was thoughts about how the robots can improve the neurovascular space. And I think I look at 4 major components. And the one is automation of dangerous aspects of procedures to make things safer, remote stroke, remote proctoring, as well as decreasing the radiation exposure. When you look at automation, as we know, we're all humans. We have human error. We can make errors. If you're tired, I'm sure you're less good as when you're less tired. And we know that robots and, for example, computers, they can do a lot more maths accurately than we can. And I think the same thing with robotic in surgery. I think some element of automation will make things safer. And for example, which I'm going to show, which we actually had to do in the device with the robots, one of the biggest risks of neurointerventional procedures is perforation of the cerebrovascular tree. And I think if you can imagine a situation where you can take the wire into the neurovascular tree, but pin it when you're doing the procedure to prevent the wire perforating the vascular tree, this would make things safer. And this could be just one example of automation, and I'll show you how we developed that as well. The second driving force, I think, was remote stroke. I think we all know that we cannot get every stroke victim into the major centers. I think people, for example, in Aspen have a stroke, how are they going to get down to Denver quickly or to Houston quickly? And I think developing a robot that can be placed there and allow the neurovascular expert to do the thrombectomy or neurointervention remotely would be great. You'll have the quality, and yet you'll cure the geographical distance problem. The third thing is remote proctoring. We know we always fly around, we proctor people, and imagine if you can have the robots sitting there helping the junior faculty and have a more senior neurovascular surgeon helping the junior surgeon even remotely. Yet again, you keep the quality, but you make things safer. And the fourth is the radiation exposure. All of us that do a lot of intervention worry about radiation, and I think this robot will allow the surgeons to be away from the workbench either a couple of meters if you're doing it in a major center, versus, up to thousands of miles when you're doing it remotely. So this started a few years ago, and this started by saying, with Alan Lumsden and myself saying, well, let's try and develop a neurovascular robot. There was a Corindus robot available, which was developed for a cardiovascular platform. So the first preclinical study was a feasibility of robotic-assisted neurointerventions, the initial experience in a flow and pig model and a porcine model. And the goal was purely to take the cardiovascular robot and use the neurovascular wires, which is the 014 wires, the 2 French catheters, and see if this is feasible. So this is the robotic system. This is the classical Corindus. That's the standard we have now, but obviously that's been developed and changed over the next few years. On the left, you can see the panel. That's the console where the surgeon sits. At the moment, this console shows these three little joysticks you sit, and you can manipulate the wires. Obviously, there's in the process of developing a fourth one now. And on the right panel, you can see the actual robot, and that is the driving force of what drives the wires, the microcatheters, etc. Not going into details. You see A is the workstation, touchscreen, joysticks, definition display, etc., etc. But as you can see, this gives you an idea what the working elements of this robot are. And this is the actual robot. As you can see, the A is the guide catheter rotation module, B is the exchange wire wires, C is a guide wire, D is guide wire rotation, and E is the support track. But that's the actual brain to the Corindus or CorePath robot. And then this is the setup. So if you watch the video, you'll see me on the left upper panel there driving the joysticks, which can be pushed forward, back, and rotated, much like that human can do. On the right upper panel, we have the cassette, which is moving back and forth as it moves the wire. On the below panel on the left, that's the flow model. And on the right side, you can see the flow model there, and you can see the wire being manipulated. So this is what we did the first time. As you can see the video, we've got the microcatheter placed into this flow model, and actually we're coiling an aneurysm with a regular neurovascular coils done purely robotically in this flow model. So that was really one of the first things we did as we started developing this technology with Corindus. The next thing we said, well, we can do a flow model. Let's start in a pig model. So this is an internal run of the pig. What we take in the micro wire, there's the wire. Again, robotically, it's a little bad wire, but we've taken it, we've driven the wire right towards the retium mirabilis, and this is done robotically. So now we've shown we can drive this wire and microcatheter. We've taken the microcatheter now as well into a flow model. We're now showing that we can take the same microcatheter and a wire into a pig, and that set the stage. We even can do a run. This had to be done manually, but we did it. Then we went ahead and we navigated the external circulation of the pig, even through a disease segment. You can see the wire going up there now. You can see the catheter following this. So this really set the stage of how we went ahead and helped develop the neurovascular space towards robotic care. The next phase was, we take the same pig. Can we coil an aneurysm, the rete? We did it in a flow model. As you can see now we've got the catheter and the microcatheter going up there, all done robotically. And you can see in the rete, which you can see there, that's the coiling happening there now. And we're busy coiling the rete again, purely done robotically. We also then said, okay, well, let's go to a stent. We did place the stent, but it wasn't photographed well, but we placed that stent robotically. And now we're going to show you how we're going to manipulate the wire through the stent. And as you can see, this is actually a really bad wire. This is not the wire I use for neurointerventions. But despite that, we can navigate that flow model through the stent, and then we can access the aneurysm through that trellis in the stent. And we can take the guide wire, and we're going to take the microcatheter, and place it up inside. Then we can call the aneurysm. So this just showed us, despite using the basic Corindus cardiovascular robot, this is all possible. So then we said, okay, what's the next phase? So that was the first paper. We did that. We said the second paper should, well, could we even embolize an AVM, with a robot? And we published that as well. As you can see now, we're taking the microcatheter into the rete. We now do a run, which just shows the contrast going towards the head. As you know, pigs have the rete before the ICA for the brain. And now we're going to slowly inject onyx. And as you can see, we're injecting onyx, which is an embolic agent, into the rete. And this was the first time it was done. We actually went ahead now and embolized a pig rete using the same material we use for AVMs in humans. And that was published. So that set the stage, and I think we did realize that now this is, this robot it's really feasible. I think, we were all worried about, pushing this forward because of the complications. And the one thing about, when you develop any technology, is that we did notice that unlike a human, where when a human you push your micro wire inside and you can you can do a push-pull technique, where you can move the wire, and as you push the catheter, you pull the wire back, and we all do that, particularly experienced neurovascular surgeons. But with a robot, you couldn't do that accurately. I would still try and do the push-pull technique and try and keep the wire back, but we did notice that that the wire would sometimes jump, and obviously for a human this would be disastrous and people would die. And so that was one of the big stumbling blocks of pushing this technology forward. But engineering has a solution, and we published this in JNS. And what we developed with the engineers was a software problem for this robot, where we can go ahead and lock the wire once we have the wire in the aneurysm or vessel. And as you can see the video playing now, on the left panel, the wire is going inside, and as we're going to move the microcatheter, you're going to see that wire jump, okay? And obviously that is dangerous. If you go to the next video, we've actually incorporated this device called the proximal fixation device, where we go into the aneurysm with a wire. We now take the microcatheter into the wire, and we found that the wire remains absolutely stable. So in this situation, the solution to the problem not only made it feasible for the robot to do these interventions, it actually is a situation where this may augment human use long term, because as a human you're always going to move the wire a little bit forward, but you can imagine having a software device that prevents you from moving the wire completely. So this is where robotics can really make a difference and make things safer. So this led to us doing the first in man in the extracranial carotid circulation. We did a couple of people, humans. We did the external circulation, and that was very successful. We were unfortunately not allowed to do the intracranial circulation, and then the Canadian group went ahead with the same company based on some of the stuff. We worked with the company, and they went ahead and called the first aneurysm, both just a simple coiling as well as a stent-assisted coiling. But this was the first in man, first in human for the extracranial circulation, and this set the stage. So obviously the topic of the talk is, can robotic intervention be used to treat a stroke? And this is the example, as you people that do stroke interventions, that's all it is. You have an M1 occlusion in this situation. You're going to go ahead and take that stent retriever with a microcatheter over there and then open it up. I've already showed you today we can do this in humans. We can take microcatheters over anything. We can drive wires. We can drive coils. We can drive stents. And we can embolize AVM. So as you can see yourself, we can do this technology right now if we had better devices developed for the robot for the stent retrievers. But this is completely possible to be done right now. So the thing is, why is remote stroke important? I think, as we all know, time is brain. We have significant geographic limitations to certain patients to get access to care. And the solution would be to place a robot in all reasonable sized centers where someone can do groin access. All you're going to need in those centers is have someone, either PA, a tech, cardiologist, or a vascular surgeon, place the sheath, and then the robot will take it further. And I think this is the best scenario, because you will have an expert neurointerventionist doing the thrombectomy in a remote site without having the patient be transported and waste that time of brain problem. So as I said, this is a real short talk. I'm not going into details, but there's another publication we did which clearly describes the benefit of telerobotic stroke intervention. And I think in my little short talk, I just wanted to show you where this technology is going. As you can see from the videos, this is real. I hope you guys enjoy the talk. I've shown you that I can manipulate wires, catheters, coil aneurysms, treat AVMs, all using the robot. And I really believe that automation is going to actually make things safer. And I think that within my lifetime, hopefully within the next 10, 15 years, which is, pretty soon, we will have this as not a standard of care, but it will definitely be developed to a level where people will be using it in geographically limited areas. Thanks very much. So I have some questions that were sent to me to answer. And the first one is, these concepts are being developed in the Western medical centers, but I think they are going to play a major role in healthcare in the medical centers and the very tertiary care centers. But I really think it's going to make a much bigger difference in rural America and the rural world. We are never going to supply enough neurointerventionists to provide the whole of India, the whole of Africa with stroke care. But you can imagine if every one of these major hospitals in that area has a robot, and we can treat these people remotely. So I think that even in countries where there's less access to experts in stroke, this is going to play a major role, and I think that's where it's going to go. So I think if I look at it on a business perspective, where it's going to be the biggest bang for the buck, it's not going to be in a major medical center like the Houston Methodist Hospital. It's going to be in the rural communities and rural countries. In answer to question number 2, in regard to level automation, there's no doubt about it, automation can make things safer. When you look at the driving car that we're developing, a self-driving car, we know at the moment it's not there for prime time, but you can imagine if we have multiple self-driving cars keeping to the speed limit, obeying all the rules, we will have safer roads. And I do think much like athletes, not every athlete's built the same, not every athlete is skilled as the same. I think not all the surgeons are the same. But I think with a lot of automation, we can standardize the way to stroke care and we can improve things. So I think that this robot's been developed as we speak further in Germany now, once the company's been bought by Siemens and there's other robots being developed. I think the robotics in stroke care and neurointervention is going to make the procedure a lot safer. Third question is the limitations. I think that the current limitations is going to be resources. I think we are not completely ready for prime time for stroke care because of the risk of perforation. But I think long term, with the development of special catheters and devices for this robot, there's going to be no limitations. My prediction is within 10-15 years' time, this will be a standard of care for rural hospitals, pending continued funding for these programs across the world. But I think this is really going to take over stroke intervention and will help sort out the geographic limitations to expert care. I agree with this question in that obviously the treatment may never be worse than the disease, and obviously with complications you worry about it. But I think, as I mentioned in the previous question, I think technology, if used correctly, can actually make things safer. So I think at the moment, if you have an expert interventionist, you will do better. But I think long term, the robot will make things safer and quicker, and I think better. And I think it'll be particularly useful in the people that are not experts, haven't been as trained as well, and in countries that they don't have access to high volume stroke centers. Complications are a concern, but we have complications even with human error. And I think with technology being developed long term, this will be improved. And I think outcomes will actually be better in about 10 to 15 years with robotic assistance. So just in close, as you can see, this has been a little bit of passion for myself and Anna Lumsden. We've done this together. I think this is the future. I wish America would allow us to have done the first in-man intracranial, not just the extracranial. But that's the way it is. But as you can see, this is exciting technology. Robots are here. They're part of the future, and we have to embrace the future. As I always tell the young residents, you're continually changing. Even as you become an old man like myself, you've really got to embrace new technology with obviously understanding and a critical mind. But I think you have to embrace this technology. And for stroke care, this is the future.